all of you are doing well. In this video, I'm going to teach you about the pneumonia. I have discussed with you people a little bit about pneumonia. Now I'm going to teach you in detail. So basically, pneumonia, we have two types. Lobar and lobular. Lobar means there is a lobe of lungs are involved, and in lobular we have the patchy involvement. So discussing it further, we have types on the basis of that on which setting the person has acquired the pneumonia. That if the person acquired pneumonia from the community, then it is called the community acquired pneumonia. If the person acquired pneumonia from the hospital, it is hospital acquired pneumonia. And for the ICU patients, admitted patients, we use the term ventilator acquired pneumonia. And pneumonia with atypical presentations, like pneumonia doesn't show symptoms like diarrhea or erythema multiforme, Stevens-Johnson syndrome. If the person is having pneumonia on chest X-rays and he is having atypical symptoms that are not shown by pneumonia organisms, then then we call it as atypical pneumonia. So discussing it further, community acquired pneumonia, we have typical agents like Streptococcus pneumonia, Haemophilus influenza, Staph aureus, and Klebsiella enterobacteriaceae. So what is the presentation? The patient present to you with the productive cough, with the mucopurulent cough. One thing I want you to remember here is that even if the patient is HIV or is having AIDS or is having the low CD4 count, but presents to you with the purulent or mucopurulent or productive cough, then we consider it as a pneumococcal pneumonia, not the pneumocystitis jirovecii. As you know that pneumocystitis jirovecii is more common in AIDS patient, but pneumocystitis jirovecii is show you the symptoms of dry non-productive cough, not the mucopurulent cough. And also it causes the interstitial lung disease. So you should remember, if the patient presents to you with the mucopurulent cough, with the chest tightness, with the pruritus, with the fever, rigors and chills, tachycardia, tachypnea, and bronchial breath sounds, you see on this, when a patient can also present to you with the hematopoiesis, with the resting sputum, with the chest pain, with the pleural rub, and this pleural rub, and the pleural rub is only in inspiration. And on examination, you see that the patient is using accessory muscles of respiration. There is subcostal recession, there is tactile firmitus, there is a dull percussion knot. Air entry is normal, and you see you can hear the crackles very clearly. You should see the bronchial breathing. What is bronchial breathing? You see the expiratory phases prolonged and inspiratory phases not as prolonged. And you see the whispering pectorology. What is whispering pectorology? Whispering pectorology means if I say the patient to whisper some words or say some alphabets, and I put my stat on his to hear, then normally we cannot hear the sound, but I can clearly hear the sound due to the consolidation effect of pneumonia. This is whispering pectorology. And egophony, if I say the patient to say E or A, if I say the patient to say E, it sounds to me as A. If and I ask the patient to say A, it sounds to me as E. That is egophony, like the alphabets are not clear to me. And this is also due to the consolidation, because pneumonia consolidate the lungs. So these are the typical signs on examination and typical features. The patient presents you fever, rigors, chills, dyspnea, pruritus, pleural rub. On examination, you see that the dull percussion knot is there. You see the air entry is normal. You see the patient is using accessory muscle. You see subcostal recession. You see bronchial breathing. Expiratory phases prolonged. Normally the two phases are equal, but expiratory phases prolonged. If you see bronchial breathing, then it means the patient is suffering from pneumonia. You see whispering pectorology. You see egophony. Whispering pectorology, you can even hear a word, even a patient whisper, and you can hear words like A like E or E like A. Then this is the patient is suffering from pneumonia. So The atypical community-acquired pneumonia is caused by Legionella pneumophila, Mycoplasma, Chlamydia, pneumocystitis, and viral. Viral is COVID-19. Okay, the presentation is gradual in onset. Okay, atypical pneumonia is having the atypical presentation, so it is gradual in onset. The patient may presents to you with the dry non-productive cough, and the patient presents to you with the headache, myalgia, GI symptoms, diarrhea that are not typical to pneumonia. And you can also see the interstitial infiltrates, or there will be no consolidation on the chest X-rays. Then this is the atypical presentation. This is not typical of pneumonia. Okay, if I will discuss about the agents of the atypical pneumonia. Let's suppose Legionella pneumophila is there. So it transmit due to the water droplets. It transmit due to the water droplets. Like if the patient is having the history of staying in hotel or traveling in cruise or ship, some expensive ship, then the patient may suffer from Legionella pneumophila because it transfers from the water droplets. The Mycoplasma, pneumonia, chlamydia, and pneumocystitis and viral like COVID-19, they are not having the typical symptoms like pneumonia. Usually the patient of pneumonia presents to you with the very severe symptoms, and in COVID-19 you might have seen the patient walking to the hospital. So this is the atypical presentation of pneumonia. And in Mycoplasma, investigations that you carry out are chest X-rays, blood tests, complete CBC, urea creatinine, blood culture, LFTs, CRP, ABGs you carry out. Okay, CBC you may notice leukocytosis, and you see electrolytes, you see urea creatinine to rule out the pneumonia caused by the Legionella pneumophila, because Legionella pneumophila show electrolyte imbalance. It shows diarrhea, it shows electrolyte imbalance, it affects the brain. And we also go for blood culture to confirm the organism. We do LFTs, we do CRPs to see the if CRP is raised, it means that there is acute infection. We see ABGs, we see the to see the saturation, oxygen saturation, and all that. We also do broncho alveolar lavage. Okay, if the patient is immunocompromised, if the patient is in ICU, if the patient is immunocompromised, you may think of pneumocystitis, GWC, or if the patient is having ground glass opacities on the lung. But if the patient presents to you with mucopurulent sputum, not the dry cough, if the patient is presenting to you with mucopurulent sputum, then this is not pneumocystitis GWC, this is pneumococcal pneumonia. So here you can see the organisms and the features. In the step pneumonia, we see rusty color sputum, and this is the most common case of community acquired pneumonia, and the drug of choice here is penicillin. And in Staph aureus, the Staph aureus is basically superadded infection. If you have pneumonia with H influenza type A pneumonia, and if you have H influenza type A pneumonia, that you have the tendency of super infections, and Staph aureus in this case infect you, and you end up in nematocele in lungs, which may burst, and you might suffer from pneumothorax by the bursting of that nematocele. So it is the super infection after the Haemophilus influenza. Okay, so it is pneumonia post influenza. Here it is written, and drug of choice here is because Staph aureus is methicillin resistant, so drug of choice here is vancomycin, not penicillin. Now Haemophilus influenza is if the patient is chronic smoker or having COPD presents to you, you may think of Haemophilus influenza because it is more common in COPD patients who are chronic smoker. In Klebsiella pneumonia, the patient presents to you with a current chalice sputum, and the drug of choice here is ceftriaxone. We give ceftriaxone. In Legionella pneumophilia, I have already discussed with you people that it occurs through water coolers, through water droplets. Patient has a history of traveling in cruise or ship or some hotel, or using some water coolers, some air conditioner, ventilator. Risk factors are alcoholic, immunocompromised. If the patient is alcoholic, immunocompromised. If the patient is having organ transplant, or then the patient presents to you with Legionella pneumophila or atypical presentation. He is having abdominal pain, diarrhea, CNS symptoms, hyponatremia, deranged LFTs, and Mycoplasma pneumonia is basically presents to you with the erythema multiforme, Stevens-Johnson syndrome, Guillain-Barré syndrome, and you know that this is atypical presentation. And so in atypical organisms, we have Legionella, we have Mycoplasma, and uh, Mycoplasma pneumonia, you know that the bacteria is having no cell wall. Pseudomonas aeruginosa presents with you with green sputum. If anywhere in the scenario you have given green sputum, and the patient is having structural lung disease or cystic fibrosis, you may think of Pseudomonas aeruginosa. Why the organisms are important? Organisms are important for the drug of choice. Like if I am suspecting staph aureus, I can't use penicillin. And if complications of pneumonia causes pneumonia effusion, abscess formation, empyema, which is pus in pleural cavity, deep vein thrombosis, pulmonary embolism, and bacterial dissemination, that bacteria may go into the blood and disseminate in the whole body. That is bacterial dissemination in mucosepsis.
Rule out the severity. To see the severity of the pneumonia, we do the curve score. So what is curve score? Here the C stand for confusion, U stand for urea greater than 7 millimole per liter, R stand for respiratory rate, which is greater than 30 per minute. If the respiratory rate is greater than 30 per minute, and blood pressure, the systolic less than 90 millimeter of mercury, or diastolic less than 60 millimeter of mercury, or age greater than 65 years. Each of these C, U, R, B, we give 1 point to each, and we calculate the score. If the scores become 0 or 1, then we may discharge the patient, we may send him home, we may give him medicines that you should take this disease medications, and you may go home. And if the score is 2, we consider hospital admission, and we ask the patient to stay in hospital, to have a short stay in hospital, and we usually these patients have outpatient stay. And if the curve score is 3 or more, that means the severity is more. So we manage in hospital as severe pneumonia. We assess for ICU admission, and the basis of the scoring, we give treatment to the patient. But if you ask me, that we give treatment to the patient on the basis of which organism is affecting him. If I suspect that the patient is affected by Mycoplasma pneumonia, he is having the atypical presentation, so I will give him doxycycline or clarithromycin. Or if I suspect the patient is having superadded bacterial infection like staph aureus, I will give him vancomycin. So it also depends upon the organism which is affecting the person. But on the curve score, we give him a treatment like if there is low severity cap, community acquired pneumonia, and the curve score is between the 0 and the 1. We give amoxicillin 500 mg 3 times a daily, or IV if necessary. Or if a person is allergic to penicillin, we give him doxycycline 200 mg, or clarithromycin 500 mg. Okay, and in case of moderate severe pneumonia, if the curve score is 2, okay, okay, so we give him amoxicillin, same as we have given him above, or side by side we also give him or benzyl penicillin 1.2 gram 4 times daily IV. So this is in addition to the amoxicillin. If the curve score is 2, we give him benzyl penicillin 1.2 gram 4 times daily IV, and we add clarithromycin 500 milligram twice a daily, or orally IV in is treatment. And what if the patient is allergic to penicillin? We cannot give him the amoxicillin, so we give him doxycycline. In also drug resistant cases, we also give doxycycline 200 mg, and then 100 mg orally, or we can also give levofloxacin 500 mg daily, which is orally we give. Okay, so I'll tell you the shortcut to remember it. In both the low severity and moderate severity, we give amoxicillin. In moderate severity, in addition to amoxicillin, we add clarithromycin and we add or benzyl penicillin. In allergy condition, if the patient, if we can't give amoxicillin, then we give doxycycline. In moderate severity, moderate curve score, moderate severity of pneumonia, we give levofloxacin or loading dose of doxycycline in addition to the doxycycline. If there is severe community acquired pneumonia, we give amoxiclav 1.2 gram, comoxiclav clav 1.2 gram 3 times a day we give, or cefuroxime we can give, or we can give ceftriaxone 1 to 2 gram per daily. Plus we give clarithromycin 500 milligram daily, or we give or orobenzyl penicillin 1.2 gram 4 times daily. Okay. If we suspect Legionella, then we consider levofloxacin 500 mg twice daily IV. You can take a screenshot of it, and this is very beautiful table.
Hospital acquired pneumonia. Hospital acquired pneumonia is also known as nosocomial pneumonia. It is defined as pneumonia occurring after, if the patient comes to you and is having pneumonia within the 72 hours of admission, then we don't consider it as a hospital acquired pneumonia. We consider it as a community acquired pneumonia. But if the patient comes to you and he passed more than 72 hours in the hospital and is now having pneumonia, then we consider it as a hospital acquired pneumonia. Okay, so these patients have a high incidence of gram-negative infection, that is Escherichia coli and Pseudomonas. So treatment we give is anti-pseudomonal penicillin, that is piperacillin, tazobactam, that is effective against the Pseudomonas. We give cephalosporins that are anti-pseudomonal, that is ceftazimide and cefepime, or we give imipenem and meropenem. We give carbapenems that are obviously effective against Pseudomonas aeruginosa. If the patient is on mechanical ventilation, is on ICU, and has acquired pneumonia after the ICU admission or after being on ventilator, then we call it ventilator acquired pneumonia. So those patients who are having structural abnormality, who are having the structural lung disease, who are having the cystic fibrosis, they are having the risk of developing ventilator associated pneumonia. So how we diagnose it? We diagnose it with fever, rising white cell count. We see if we see infiltrates on chest x-rays, if we see purine secretions coming out from ETT tube, and investigations we do out tracheal aspirate, we do bronchoalveolar lavage, we do thoracoscopy, that is most accurate, and we can also do open lung biopsy, but lung biopsy usually. So this is all about the ventilator acquired pneumonia. So how we treat the ventilator acquired pneumonia? So we give anti-pseudomonal penicillin, piperacillin, tazobactam, or we can give cephalosporins, or we can give imipenem, meropenem. You can select any one of these, plus any one of the following, like levofloxacin, moxifloxacin, gentamicin, azithromycin, plus MRCA. For MRCA, we can select vancomycin or linezolid. This is the treatment of ventilator acquired pneumonia. This is all about pneumonia. I hope you liked the video. Don't forget to subscribe my channel and like the video.